So my job is to speak on aplastic anemia and IBMFS in children, our PJ experience. And what I've done is I'll speak on our experience of ATG and cyclosporin in pediatric acquired aplastic anemia and summarize the Indian studies and also talk about the unit's experience on NGS in bone marrow failure in PGI Chandigarh. So this is the first paper that I'll be talking about, aplastic anemia in children, how good is immunosuppressive therapy. So this is the pediatric hemonc unit's experience. So it talks about 43 patients, children below 12 years of age. Study was done over 5 years, acquired aplastic anemia who received ATG and cyclosporin. So the standard workup, besides bone marrow, chromosomal breakage study, of course, it has to be negative in all patients before ATG can be given. And it's always good to do an ultrasound abdomen as well, because in Fanconi, sometimes one can pick up horseshoe kidneys or other renal anomalies, and that could be an indirect clue to Fanconi. HLA typing whenever the money was conducive for a transplant, and flow to look for PNH clones. Although I've always wondered what's the real practical use in pediatric acquired aplastic anemia for management purpose. The usual serology for viruses. And recently we've also started doing ANA in older aplastics, because apparently even SLE can present with aplastic anemia. So the standard dose of equine ATG is the 40 milligram per kilo per day for 4 days. And my understanding is that 2 brands are available. One earlier at GAM Pfizer was available, which is no longer available, and the Bharat Serum. So the choice was patients, caretakers, depending on their finances or their choice. And a PICC line was inserted in most of the patients. Although while preparing this talk, I wondered why a PICC line is really necessary for giving ATG. And so I just looked at the literature for PICC line or peripheral vein for ATG, and maybe after the talk, others could contribute. So I found several papers which spoke on giving equine ATG through a peripheral vein through a simple cannula. In fact, in 2013, there was a review published on this as well, and at least 2 or 3 more publications. So the manufacturer recommends that ATG should be given in a high flow vein to reduce the incidence of thrombophlebitis. But there are reports that ATG can be given from a peripheral vein with no additional adverse effects compared to central administration. And the researchers in the past have added a small amount of heparin to reduce the thrombophlebitis, the advantages being obvious. So if others can pitch in as well, whether they would consider giving ATG through a peripheral vein, or do they consider a PICC line mandatory for ATG, or is it just a mind block that all of us have that one needs to have a PICC line for giving ATG? So the standard administration is to use methylpred for the first 4 days to reduce the incidence of serum sickness, along with oral steroids for the first few weeks and then tapered. Cyclosporin dose, again, is mentioned differently in all literature, anything from 5 till the up-to-date mentions a dose of 15 milligram per kilo per day for pediatric aplastic anemia below 12 years of age. So it's quite variable. So we use 5 to 6. And even the cyclosporin drug levels I'm not sure if there is any evidence in aplastic anemia as to what level is correct. So we've been kind of following this 150 to 250, but again, I would like others to tell their, basis of cyclosporin level in aplastic anemia. So for how long do you give it? Even that is a struggle in the clinic. So we typically give it for full dose for at least 6 to 12 months after the so-called best response. So the best response is for that particular patient. So maximal response attained individually in the counts for that particular case. You just look at the CBCs and you kind of get a feeling that, it doesn't seem that he's going beyond this number. And typically, we would look at it at least after giving cyclosporin full dose for 6 months. And then again, tapering is a big question as well in the clinic. So we would consider it after 6 to 12 months of stabilization of counts and reduce it by about 5 to 10% every 4 to 6 weeks. So a response definition is important because all the papers talk about these definitions. So complete is like normal counts, normal hemoglobin, platelets, and ANC. So partial is transfusion independence, but not meeting the criteria for severe disease. So the ANC would be more than 500, but less than 1500. So non-response is persistence of severe aplastic anemia. So 43 children over 5 years, so median age 10 years, because our pediatric cutoff is 12 years. Severity, as you can see the numbers, majority were either very severe or severe, and that's how we see it in the clinic. And about 10% moderate, but transfusion dependent. So I don't know if it's visible. So pediatric aplastic anemia, 43 patients. So first we always look at the HLA matching. So if you look on the right side, it was not performed in 31 because lack of funds for transplant in the majority, 28, no sibling in 3. And in the rest, 12, unfortunately, there was just no match in as high as 12 patients. So they all proceeded for ATG and cyclosporin, 43. So the parents chose whether they got ADGAM or thymogam. So 1/3 got ADGAM and 2/3 received thymogam. And the responses were similar in the two arms. I'll come to that in the next few slides. So PNH clone positivity, it's done by flow. So about 23% patients had PNH clone. So I think there is some discussion that if the PNH clone is negative, rather if it is, so then it cannot be an inherited bone marrow failure syndrome. But I think studies from our own center have shown that it could be positive even in inherited bone marrow failure syndrome. So I'm not sure if it can be used to distinguish between the two. So minor and major clones in half each. And out of these, only one patient developed the full features of PNH. And as we know, PNH is really uncommon in the pediatric age group. So serum sickness is relatively uncommon. It was seen in about 5% of the patients managed with oral steroids. So looking at the response, so complete response in 1/5, 21% patients at a median of 24 months, and partial response in about 1/3 at a median of 12 months, and no response in 46% patients. So if you want to make it look a little bit more positive, you can combine the complete and the partial, and the figure turns out to be 53%. So the outcome is, in the West, is reported to be, I would say, about 20 to 30% numbers higher than this. So the other things that we could get from the study was that response at 6 months was associated with prognosis. All 9 patients who had a complete response had some response, either partial or complete, by 6 months. So this was significant. So if a patient responds by 6 months, he's likely to have a better prognosis. But at the same time, one would always see some patients who would respond late. So does the severity of aplastic anemia affect the response? So answer is no, at least in our study. I know that there are some papers which say that the outcome of very severe is supposed to be better than moderate, but in our 43 patient numbers, we did not find this. So cyclosporin tapering, so median duration of 14 months, and the IQR is variable from about an year to 20 months. So it could be stopped only in 20% of the patients by the time the study was completed. And all these patients were in CR, and after a median duration of nearly 2 years that the cyclosporin was stopped. And it is continuing in the large majority of the patients with partial response, and it can be a struggle how to decide tapering cyclosporin in patients with partial response, whether to keep them on a lower dose or to try to stop, and then they will relapse, and then one may have to go back to the full dose and then start the tapering several months later down the line. So that's always a struggle. So these patients who are still on cyclosporin are on it for this IQR range. So relapse is a relatively small number because I guess many did not respond. So 3 who were in partial remission had a relapse and 1 in CR. In 2 of them, it was, sorry, in 3 of them, it was within 8 weeks, and in 1 after 20 months. And here, often we see that when cyclosporin is restarted, most of them tend to have a response again. So what about the question about iron overload? Sometimes one tends to forget sending serum ferritin in these patients. So 23% of them were on Defra-Xerox, most of them non-responders and transfusion dependent, and 3 partial responders as well. All of them had a ferritin exceeding 1,000. But here we have to remember to use a lower dose of Defra-Xerox, not like the thals, wherein typically we use 30 to 40, because they are receiving cyclosporin as well, and the creatinine tends to shoot up. So 2 patients, I mean, 2 patients did have rising creatinine, and we had to do transient holding to allow the creatinine to roll back. So looking at the deaths, so 1/4 died post IST. None had responded, and they died at a median duration of 6.3 months. And the usual causes of bleed and sepsis. And one had transformed to AML 11 months post ATG, and he was a non-responder. So in LMICs, you would always have patients who would be lost to follow-up. And so this is the survival curve. Overall survival is 63%, but this just means that these are the patients who are alive. So it's dead or alive, overall survival. And one has to always remember that the ones who are alive, some would not have a response and some would be having a partial response, and they would be supported by transfusions. So the overall median duration of follow-up was 22 months and longer for responders. So what happened to the non-responders? There were 20 of them. So their median follow-up duration is for about a year. So about 60% would kind of died, because you assume that the ones who are lost to follow probably would have died at home. The rest 7 are transfusion dependent, alive, and they are like worse than thals. They keep on getting transfusion every 2 weeks. So ATG brand, the 3-year overall survival was similar in the 2 groups of ADGAM and thymogam. And the PNH clones are in the literature, there are variable reports as to whether it's a marker of prognosis. We did not find difference for prognosis, whether the clone was present or not. And there are also studies which say that a higher absolute lymphocyte count predicts survival. So we did not find a difference in response or survival with the absolute lymphocyte count. So I'll spend some time on this slide. So I have fished out the Indian studies on ATG and cyclosporin. I could have missed some because some would be complete data of adult and pediatric. So I'll start from the last. This was in 2010 from CMC Vellore. I think they compared the data of ATG cyclosporin with transplant. So 70 children. So the complete response is 17%, partial is 21%, overall survival is given as 37%. So the next one is from AFMC Pune, and I think it was an outlier with fairly good results, 24% complete and partial of 64, with quite low numbers of non-response and mortality. And from BHU Varanasi, 70% non-response and mortality. And from Lady Harding Daily, 60% non-response and mortality. From GCRI Ahmedabad, again, decent numbers of complete and partial response. And this one is the current study, which I had projected with about 46% non-response and mortality. So what is the reason for lower response in India as compared to the West with ATG and cyclosporin? We don't know. We often talk about a longer symptom to diagnosis interval and a longer diagnosis to therapy interval. So we looked at that. So it's actually fairly comfortable numbers. The median duration of symptom to diagnosis interval is 1.4 months. And the diagnosis to therapy interval in our study was 2 months. And the recommended as per the British Society BSH guidelines is less than 6 weeks. So it actually does not look so bad. So one wonders whether one is some cases of IBMFS or MDS are being missed out, but there would not be so many as to explain the 20-30% difference in the response rates with ATG in pediatric aplastic anemia. So this is another study from the from the lab hematology unit at PGI Chandigarh, a fairly old study by Dr. Neelam Verma about 15, 16 years ago. So this is just a data compilation of chromosomal breakage study, both in pediatric aplastic anemia and adult aplastic anemia. So out of 54 patients of pediatric aplastic anemia, 24% had a positive chromosomal breakage. And in the adult, out of 40, none was positive. The paper really does not talk about how many of them were symptomatic, had phenotypic features of Fanconi's, because sometimes it's a dilemma in the clinic as the questions were being asked. Sometimes you have a 9, 10-year-old aplastic anemia who's tall and well built, and you send off a chromosomal breakage, and after 3 weeks, you get a report that the chromosomes have not grown. And then you wonder whether you need to send the test again, and that will take another 3 weeks. So, so that is a dilemma sometimes one faces, whether one should give ATG without looking at a chromosomal breakage study, which I think one can answer on a case-to-case basis. But as a general rule, one has always been taught that in pediatric aplastic anemia, one is not to give ATG till one has a chromosomal breakage report in front of you. So before I go to the next paper, just to show some pictures of Fanconi's, which we see every day in our clinic. So this girl, if you can see, the eyes, they have this microophthalmia, so small eyes. and always look at their thumbs, because 50% of them would have some thumb anomalies, and here too. And this child was a 15-year-old known Fanconi's, and he came with a chest mass. We assumed it would be a malignancy. We could not prove it because the family went home. But again, we all know that Fanconi's would present with second malignancies. So more examples of kind of abnormal toes and hypoplastic thumb, and again, some more thumb anomalies in patients with Fanconi's anemia. So this is the next study from the pediatric hemonc unit at PGI. So this was a DM thesis done by Prashant and guided by Pratik Bhatia. So this is an NGS study done in patients with bone marrow failure, and done in the lab of Pratik Bhatia over 5 years, 14 to 2019, published last year. So what was done is that they divided patients into groups. So group 1 is suspected IBMF as based on the clinical phenotype and the usual lab investigations, and NGS was performed in 27 of them. And because it was a thesis and the money was limited, Fanconi anemia patients who had a typical Fanconi anemia phenotype and a positive chromosomal breakage were excluded, because it was considered not a good utilization of resources to do it in patients who already had a chromosomal breakage positive. And the second group is more interesting, that these are the patients of idiopathic, so-called idiopathic acquired aplastic anemia who received ATG cyclosporin, but had a partial or no response at 9 months. You know, when a patient with aplastic anemia does not respond to ATG, you always wonder whether he could be an inherited marrow failure patient. So the lab designed this targeted NGS with the 33 genes, and this was the system which was used to perform the test. I thought I'll say it, but I'll just avoid for more comfortable feeling. So, and this was supplemented with whole exome sequencing where necessary. So this is the gene panel. So I think Fanconi anemia has, I think, at least 17 genes or maybe more. And the common ones are the A, C, G, or although I think in India, the data may be different. So these 4 were included. So Diamond-Blackfan anemia, so these were the ones which were included, including GATA1. And here is DKC, congenital neutropenia, and Shosman-Diamond. And some more, the less common ones, the SAMD9, which was being spoken of in the earlier talk, leads to the Mirage syndrome, RUNX1, and MPL for congenital amyloidocytic thrombocytopenia. So the whole exome sequencing was performed in group 1 cases, the IBMF cases, who were negative or inconclusive on the initial NGS. Because if they had some somatic features, one would always wonder whether the NGS has missed. And all the pathogenic, likely pathogenic, and the VUS, the variants of unknown significance, were confirmed with Sanger sequencing. So just for comparison, I checked the MedGenome website, and the commercial panel includes about 93 genes. And one is always curious about the cost. And I think this is the price that they quote to us. It could be different at different places. And the 33 gene panel, which is available at PGI, is offered at a price of 8,000 rupees to the general patients. So the flow chart is children below 12 years with bone marrow failure, and 53 were idiopathic. So 9 died within the first few months, and sorry, the 11 died in the first 9 months. So partial responders were 39, and NGS was done in 15 of them because of limited resources. And on the other hand, the DBA phenotype 23, NGS done in 16. Fanconi anemia phenotype 1 was chromosomal breakage negative, so NGS was done. Dyskeratosis congenita 2, both it was done. And in unclassified bone marrow failure syndrome, NGS was done in about 8 patients. So Diamond-Blackfan anemia, about 23 cases. Median ages, I mean, they present in early infancy, really low hemoglobins with a high myeloid erythroid ratio, and that's the way you make their diagnosis. And the Diamond-Blackfan anemia, the typical findings of a kind of a bifid thumb. And sometimes they are so transfusion dependent and they grow old and they are just a part of the thalassemia daycare centers, and they just get, they become a part of thalassemia protocol rather than any specific thing. And some of them receive steroids for long. And this is a case of avascular necrosis of femur head receiving steroids in PRCA. So 23 cases, and these are the various somatic manifestations which were seen. Most commonly, we see short stature and microcephaly. And so steroid is the typical drug which is used in Diamond-Blackfan anemia. And one has to remember not to gave it below 1 year of age to avoid cognitive impairment. And the response at the last follow-up was about 70% in our cases. So the NGS was performed in Diamond-Blackfan anemia, and mutations were identified in 50% of the cases, RPS19 and RPL5, and one was VUS. And a whole exome sequencing was performed in 5 of these cases, and it was non-contributory, indicating that the NGS was good enough and had possibly not missed any mutations. So 18 cases of Fanconi anemia. Chromosomal breakage, as I said earlier, was positive in 14 out of 15, and one was negative, and he had a FANC-A mutation on NGS. All of them received stanozolol. None of them got the transplant for various reasons. So 2 cases of dyskeratosis congenita, they had a suggestive clinical picture. And these are the 2 mutations which were identified, TINF2 and TERT gene. So the more interesting is the unclassified bone marrow failure syndromes, 13 of them. So it's a heterogeneous group with pancytopenia and somatic malformations not fitting clinically into any established IBMF. So NGS was performed in 8 of these. So one had Fanconi. So CSF3R is found in congenital neutropenia. RUNX1 is associated with MDS and then DKC. And again, the enigmatic VUS and no mutations in 2. So the idiopathic aplastic anemia group treated with IST, 39 had only a partial or no response at 9 months, and NGS was performed in 15 of them. And 2 of them had pathogenic mutations. So DKC1 in one and SAMD9 in another. So of the 15 patients who did not respond to ATG at 9 months, 2 of them had a pathogenic mutation. So there would always be some patients of so-called acquired aplastic anemia who get ATG who would have some IBMF. The question is whether it is more cost-effective to do it at the diagnosis or do it later when they do not respond to ATG. I'm sure at some point of time when one would end up doing all of them at diagnosis because that's a comfort feeling when the cost would even be less in the future. So the last 2 slides. So to conclude, so in Diamond-Blackfan anemia, the pathogenic mutations were found in about half, and in unclassified bone marrow failure, again in half. So, and dyskeratosis congenita, we know, is a highly variable phenotype, and none of the 3 patients had the typical triad, and one was actually being treated for a DBA. And for idiopathic aplastic anemia, I've already told you the response rate. So complete is only in 21% and partial in 32%. The 2 available brands had a similar response. And of the patients who had a partial or a no response, we could identify some pathogenic variations in 2 of the 15 cases. That is 13% cases of so-called acquired aplastic anemia. So I'll end my talk here. So this is the pediatric hemonc team. Not all of them are present here. And this is our recently renovated ward. And thanks to the patients and their families. Thank you so much.